Start again. There you go. Welcome. Welcome to our series of 3 webinars on promoting healthy body image and sexuality in pediatric cancer patients. My name is Audrey Ludik. I'm the Program Development Manager for CHOC Childhood Cancer Foundation in South Africa. CHOC's vision is that all children and teens with cancer or life-threatening blood disorders have access to comprehensive care and support. And our mission is to support children and teens and their families who have cancer or life-threatening blood disorders, improving early detection and supporting effective treatment. So one of our goals in our strategic plan is post-treatment support, and that includes continuous support to our survivors. So during focus group discussions and individual conversations with long-term survivors, it became clear that one of their many struggles is that of a healthy body image, sexuality, and fertility, a difficult conversation. But we have sourced international experts to share their knowledge, trends, new research with us. We also invited survivors who bravely are willing to share their journey with us. And we invite you as the participants to take part in this conversation. You are welcome to put your questions in the chat, and then we will address it at the end of the talks. We will also be doing 2 poll questions during the webinars, and we would really appreciate your feedback. So as I said, today is the first of 3 webinars, and I hope that you will really be able to join all 3 of these webinars and also promote it to your friends and families, and especially to our long-term survivors. And today we will focus on fertility and long-term effects. And we are very, very privileged today to welcome our experts from the Princess Maxima Center in Pediatric Oncology in Utrecht in the Netherlands. And we are so thankful for your time and your expertise. You are most welcome, even if it's virtually, but welcome to South Africa and to the webinar. And also we have one of our long-term survivors, Zuki, who we'll also introduce later. So, with no further ado, our first speaker is Dr. Helena van der Paal. So Helena is a senior staff member of the Later Expertise Center for Adult Survivors of Childhood Cancer at the Princess Maxima Center for Pediatric Oncology. She's also the chair of the PanCare Network. And I must say, when I asked all 3 of these ladies for a very wonderful introduction, it was like 1 sentence or 2 sentences. But Helena, welcome. I'm going to hand over to you, and we are looking forward to listening to you, to your talk on the late effects of childhood cancer, fertility, and sexuality. Welcome, and over to you.
Thank you very much. I'm very, very honored to talk to you today about something very dear to my heart, late effects and the fertility of childhood cancer survivors. I will start sharing my screen for the presentation and put it in presentation mode. I hope you can see it all. I will focus on fertility, of late effects of childhood cancer treatment on fertility, and Irene, my colleague from the Princess Maxima, will focus on sexuality. So this is a picture of the Princess Maxima Center in Utrecht in the Netherlands. We have a national pediatric oncology center, and we realize we are very fortunate to have that. Our mission is to cure every child with cancer while providing optimal quality of life. Of course, we try to do this for the Netherlands, but we also try to reach out and have an outreach program for the rest of the world. In the Netherlands, we have 600 new children with cancer yearly. And we also have here on the floor, on the basic floor, we have the late effects clinic, and we see there all survivors after 5 years. So to tell you a little bit about cancer survivorship, I will give 2 overview slides before I go to fertility. So in developed countries, 80% of childhood cancer survivors will survive. But we do know that 75% of them has at least one late effect that will influence their life. So we advocate that survivorship care is needed. It doesn't stop with cure. And we also know that about 20% of survivors of childhood cancer have fertility problems. And there is a lot of knowledge about fertility problems after cancer treatment. And together with the International Guideline Harmonization Group and PenCare, we have made guidelines for surveillance. So in Europe, there are more than 400,000 childhood cancer survivors. I do not know these numbers for Africa, but we should, so I will look into that. For childhood cancer survivorship, we advocate that survivorship follow-up care is necessary throughout the lifespan because we want to detect and treat late effects as early as possible. But we also say that it should be evidence-based and risk-based. So not everybody is needing an echocardiogram, for instance. And I already told you about the guidelines, and the goal is to improve long-term health outcomes and, of course, quality of life. So then we go to fertility. There are 6 guidelines currently, and you can find them on the website www.ighg.org. 2 are for survivors, premature ovarian insufficiency, so that's early menopause, basically, and male fertility problems. And there are 3 guidelines related to fertility preservation, and Mariana will tell you more about that later. And there's also a guideline when you do become pregnant about obstetric care. So what do we know? That about 1 in 5 survivors may have fertility problems. It does not mean that you will not have a child, but you may have problems. But more than 80% have questions about fertility. So this is really the most important topic talked about in my clinic. And the other thing is also that fertility problems are different for male and females. And it's really important to understand the need and experience problems for survivors, for family planning, and also for counseling. So who's at risk for female fertility problems? If we look at the evidence, there's maybe cranial radiotherapy to the ovaries. This is the most important one, alkylating agent. But we also know that in a lower dose, cumulative dose, there's no significant increased risk. There is a little evidence about a stem cell transplant, and when you take away 1 ovary, there's only 1 ovary left. But the main problems are here in radiotherapy to the ovaries, alkylating agents, but only in the higher doses, and stem cell transplant. So if you have received other treatments, not those, then the risk is not different than from the general population. The idea is here that when a girl is born, you have all your eggs in your ovaries, and this will gradually decline during lifespan. And when you have no ovaries left, this is menopause. And we think that chemotherapy and radiotherapy may damage the amount of eggs and makes that drop at once, so that you will reach menopause sooner. So what else do we know about female survivors? We study this in the Netherlands, and we know that 86% of female survivors have a desire for children. This is not different than the normal population or their siblings. And about 12% of female survivors consult a reproductive specialist because they are not able to have a child. This is slightly higher than the normal population, but not a lot. What is important is whether somebody is having a partner or not, and survivors are less likely to have a partner. So this does maybe play a role. And the other thing that was really striking is that female survivors are younger than their controls when consulting a reproductive specialist. So maybe they were more concerned about their problems. So what can we do for girls and women? We can investigate your fertility. After puberty, if you have a regular menstrual cycle, this is really good. But we can send you also to a gynecologist. They can do blood analysis and count the amount of follicles that are still left in your ovaries. And that's a measurement for how fertile you are. It's not the only thing, because there's a lot of more necessary to be able to conceive. But this does say something. If there are fertility problems, we can send you and your partner to a reproductive specialist. And if we can also discuss other options like adoption. And if you have problems coping with fertility problems, then we can talk to you or send you to a psychologist. We do not know whether fertility preservation after cancer treatment will help, but that is under investigation. So, who is at risk for male fertility problems? That's a little bit the same as for females. It's radiotherapy. The higher risk is for the radiotherapy to the testes and the alkylating agents, but a little bit they are a little bit more susceptible than the ovaries. Of these, cisplatinum, stem cell transplant, and unilateral orchidectomy, it may slightly change your risk. So what else do we know about male survivors? This we also studied in the Netherlands. About 75% of male survivors have a desire for children. This is a little bit lower than their siblings, but not significant. There is a difference whether a survivor is married, whether or not he or she is employed, and the level of education. That also plays an important role in the desire for children. More male survivors consult a reproductive specialist, but only half will use the assisted reproductive treatment that is offered, and half will father a child. So what can we do for boys and men? For boys and men, it's more easy to investigate fertility. We can do a semen analysis, and then we have a result. We can also send you to a reproductive specialist or discuss other options. And of course, we can talk to you and send you to a psychologist. Fertility preservation after cancer treatment may not be, probably not necessary, is may not necessary for men, as we don't see a decline in fertility if you are fertile. So I have some practical tips. It's really important to know your precise treatment, as this can say whether you are at risk or not. And you have to remember that in the general population, 1 in 10 persons will also have fertility problems. And having problems is not the same as not having or not able to get children. It may be more difficult, but it's not uncommon. So that's the other message. Most survivors fulfill their desire for children, and it's really important to talk to other people. So if you have any questions about fertility, please ask your doctor. Thank you. Are there any questions, or are we
Helena, yes, I didn't see any questions in the chat so far. So I really want to invite everybody, please put your questions there. Thank you for an amazing talk and so many insights. I'm sure that we will have to reflect on this much more and think about what you've said. Thank you very much. So I think we're going to put a poll question now. And I want to ask, as a childhood cancer survivor, do you have any problems with fertility after your treatment? We'll give some time for you to answer that question. As a childhood cancer survivor, do you have any problems with fertility after your treatment? I hope there are some survivors on the webinar. Wayne, do we have any results yet? We'll just wait and give it a few minutes. Okay, we see, just wait a second. People still need to answer. Yes, we really invite people to answer. I think maybe when we've got more people on the webinar, we can put that question up again. Wayne, let's take that off for now. Okay. All right, we're going to wait a little bit longer. Okay, so thank you, Helena. That was an amazing introduction to this whole conversation. I'm now going to introduce Irene Igoshi to you. She's a nurse practitioner in oncofertility at the Oncofertility Clinic at the Princess Maxima Center for Pediatric Oncology. She says that the impact of fertility questions can have on both children and their parents and survivors. Those difficult questions, that's what drives her as a nurse practitioner to work with primary care providers, gynecologists, urologists, the clinical embryologist, and to provide quality fertility care. I think what touched me the most was the beautiful way how she said, it is an honor to be in this conversation with the families and the children. And I'm very excited to hear about your talk. Irene, please talk to us on the possible effects of childhood cancer treatment on sexuality. You can share your screen and you can go ahead. Welcome, and thank you so much for your time and sharing your expertise with us.
Thank you so much for this kind introduction, Adri. I'm very happy to join you all. In the meantime, I will share my screen. I'm indeed a nurse practitioner in the Princess Maxima Center. I'm a colleague of Helene van der Paal and Marianne van der Wetering, who will speak later. And today I have been asked and happy to give a talk about concerns about intimacy and sexuality after cancer. When we speak about intimacy and sexuality, it's always important that there's a me and my self-image, and that we talk about we and the relationship we have together. Me and we need to be in balance, and if this is not in balance, then there is a dysfunction, and the dysfunction will show itself in the intimacy and the sexuality in the relationship and in what you experience yourself. What's also important in intimacy and sexuality is our physical condition, but also our mental condition. And the influence from both physical and mental condition, we see this on our sexual relationship. And if there's a disbalance, then there's most likely less desire for sex. So this is not typical for childhood cancer survivors, but for the whole population worldwide. But there are some factors which really are very specific for survivors of childhood cancer, and we'll talk about that more. So when you have had childhood cancer and you had a treatment, maybe your self-image may be influenced. Your body perception can be different than before you had the cancer if you were not that young. Sometimes you gain weight during treatment and the weight stays, or your weight is less. So you might experience your body different. Your self-confidence might have changed. And there's a very big chance that you have physical effects of the cancer or the treatment, and they might be visible or not visible. For example, if there had to take an amputation had to take place, then it is then it affects your body hugely, of course. But maybe for women, they have a different menstruation cycle, and it also can affect them in their self-confidence. If you have problems with fatigue, if your energy is reduced, if you have stiffness in your body, in your limbs, it also might influence you. And you might have a different sensation in your skin or further in your body, maybe some itching, numbness, or hypersensitivity due to the chemotherapy. That also changes your body. And all of this may end up that you feel some shame, that you are insecure, that you have a fear of failure, maybe you are down. All of this, these aspects, they give pressure on yourself, but also on the relationship. So let's look further, not only at these aspects, but how can sex feel different during or after the treatment? Well, as we said before, fatigue complaints and changes in your body, those are a big part of how you can have a different experience in intimacy and sexuality. Maybe there is still some stress or anxiety. As we said before, it's not only your body, but also your mind. So if you experience stress or anxiety, maybe you are worried about if the cancer is returning, or about some late effects you have from your treatment. Well, those feelings may negatively affect your desire for sex. And if you have less desire for sex, then probably you will not be able to get an erection or an orgasm, because erections and orgasms, therefore you need your body and mind to work together. So if at one of those, or maybe both, are not optimizing performing, then you most likely have problems with this. What we also see often is that there are maybe mucous membrane damage and vaginal dryness. So this may damage the vaginal wall or the mucous membranes of the penis. So therefore, sex or masturbation may be sensitive or very painful, and that does not help at all, of course. But you also can be intimate with your partner without penetration. So all of this means that it takes courage to speak about this and to admit that these problems are bothering you. And it is important to know how you feel about yourself. Because if you do experience negative effects in intimacy or sexual intercourse, then it's very important that you are happy with yourself. And therefore, we find it very important that you experience self-love, because you need to be confident about yourself and you need to be happy with yourself. If that is not the case, then it's very difficult to give yourself in a relationship, even without intimacy or sexuality. And for self-love, you can use affirmations. So we advise sometimes to use sentences. affirmations, and we advise to use them every day, but they need to be suitable for you. So these are examples, but I really would be happy to invite you, men and women, to make affirmations for yourself. You can think of these affirmations. I'm good the way I am. I love myself. I'm grateful for everything I have. I believe in myself. I choose to love and appreciate myself, and I value myself greatly. If you do this every day, it will change your mind, and maybe it will give you a different perspective. Because you need yourself in a communication with your partner. And communication together is really of great importance. And especially in communication about intimacy and sexuality, we do have some advices, and we find it very important that there's a quiet place to talk. So if you are sitting together at the table and you are both doing some work from home and you think, oh, now we can talk, that doesn't function. So you need to have some quiet time on the couch, no animals, no children, no phone, no social media, and just talk with each other about things that are important. For that, it is important to know what do you yourself want? What do you like? What do you prefer? So therefore, it's also the self-love and understanding yourself of big importance. And that asks a lot of courage. So show courage to yourself to feel what you like and to ask what you want. And therefore, it's also important to listen to your partner, because again, this is not specific for childhood cancer, but this may be so private and so sensitive to talk about this subject that it is important that your partner experiences respect and time and space also, and that you listen to your partner as well. And also look carefully at what the other person is expressing. Sometimes verbal language and non-verbal language is not the same. So be clear. If your partner says maybe, or if you say maybe, then often you mean no. And it doesn't help if you say maybe and then you go do something, but you don't like it at all. And then you experience some hesitation, and your partner will feel this. And then you go on a hill down together, and that is not what you want. So be clear, say yes or say no, but don't say maybe. And show what you think. So if you hesitate, you can say, I don't know, please, let's stop for a moment. And I need to think about this. And I don't know the words, but give me some time and maybe you can help me to find the words. And be aware of your body language. And don't wait too long. So if you are going to make a romantic evening together, don't put on your nice clothes or sexy clothes, but talk before this romantic evening. That really will help you. So which aspects make that you maybe don't feel like having sex? When you're busy and tired, if you're depressed or sad, have we talked about this? Insecurity about your body, medication for diseases, but also medication sometimes which contains hormones or hormone preparations. Therefore, we advise to ask the doctor who prescribed you this medication to ask, can this influence my experience in sex? It's a normal question, and it's very good if you ask this. And also, if you have had sex with your partner and it was not pleasant, then you will not feel like having sex either. If you have problems in the relationship, if you are irritated, that does not stimulate. And for all people, if the crush is over, the first crush, and the relationship and sex go into a boring position, then it doesn't help either. Or unpleasant memories of sex. So when we look at this, we can say there are special aspects when you've had childhood cancer. And there are also a lot of aspects which are for everybody in the population. but we really would like to stimulate you to talk. Please talk, talk, talk. And please ask for help to talk about this. Because if you have worries and concerns about intimacy and sexuality, it can be very difficult. And please find the courage to talk about this and to ask for help. Thank you. So I'll stop sharing and see if you have any questions.
Thank you, Irene. Wow, it's not easy, eh? But as long as we are open and we talk about it and we trust our partners enough that we can say, this works for me, or this doesn't work for me, or have patience with me, or let's work through it together with a therapist. So this is very important conversations, and it takes a lot of courage. But I want to encourage the survivors to take that step and really look after themselves and their sexual self. There are some questions in the chat from Daniel and from a cancer survivor in Malawi. I think the one that I would like to put to you is it's from Daniel Mackenzie from Zimbabwe. And he says that we have seen that our girls seem to become sexually active, having reached puberty. Is this normal? And then suddenly love themselves and boys. I don't know if you can answer that question, Irene.
Yes, so thank you, Daniel, for this question. Yes, it is normal because childhood survivors, they did miss out on quite some stuff. They've been hospitalized often for quite some time. And when the treatment is finished, then they start to explore themselves. So having reached puberty, then it's very normal to discover sexuality and be active. And we find it also normal that they experience in which gender they love. Sometimes a girl or a boy don't know if they like somebody or love somebody of the same sex, or maybe they love both sexes. We think it's not abnormal, and we think it's great that girls and boys are discovering themselves and sexuality. But we would like to stimulate boys and girls to do this in a safe way. So with people they know, and use condoms, not only so they don't get pregnant, but also to prevent sexual diseases.
Thank you, Irene. I think that was a beautiful answer and a really good answer. The other question is from a childhood cancer survivor in Malawi. He said, who had been previously being treated in South Africa. So welcome to this conversation. But he said, I was diagnosed with leukemia at the age of 8 in 1992. As a country, there is no talk of how treatment can affect one's sexuality. I would like to advocate for it, but where do I start? Especially in the African context, that's a difficult. I don't know if you want to answer that or leave it for one of the other panelists.
I think maybe I'll ask Marianne to answer this question. Marianne has been working in South Africa for a long time. So I'll make place so Marianne can speak in a microphone.
Thank you.
Oh, you need this one.
Oh, yeah, it feels like coming home a little bit in South Africa. Yes, you're quite right that it is a topic that needs to be addressed in South Africa and other African countries. And yeah, the way to start is what you are doing now via the foundation, trying to get the news going, that there's more and that people dare to talk about this and dare to ask their nursing staff, their doctors about what can be offered at the start of treatment and at the end of treatment into survivorship. So yes, there's a lot to be done, but I think you are starting with these talks.
Thank you very much. Yeah, I think there's so many taboos and taboo topics in, oh, there goes our load shedding, but I'll try to continue.
That even feels more like being home.
Yeah, this is South Africa, but we're in the dark. If it's load shedding, then we're back. But I hope that after this series, we won't be in the dark anymore about our sexuality and fertility, and that we will really have the courage to stand up and to talk about it. Because the more you talk about it, the more questions will be asked.
Yeah,
absolutely, absolutely. Okay, so it's an interesting, the poll questions, we took it off and then couldn't show the results again. The question was, as a childhood cancer survivor, do you have any problems with fertility after your treatment? And 0% said yes, 33% said no, and 67% said, I don't know. It's very interesting. So I think most people, until they come to a stage where they feel that they want to have children, only then do they discover that there are fertility problems, and then unfortunately it is too late. But let's go into conversation. Now we're going to talk to Zuki Mkwefu, and I love Zuki very dearly. She's a long-term cancer survivor of CML and ALL. And Zuki actually have a beautiful story, because when she was a teenager, they gave her literally a few days to live. And then there was a visiting doctor who recommended a trial on Gleevec, and it worked a miracle in Zuki's lives. And Zuki now passionately gives back to a CHOC as a CHOC community trainer, spreading the message that early detection saves lives. And Zuki is so brave that she is always willing to also share her story. So Zuki, welcome. It is great to have you on the conversation, and I'm very excited that you are going to share your story from your heart. So I want to ask you, as a young woman, how did you feel when you got the message from your treating doctors that you may not get pregnant?
Audrey, afternoon, everyone. Audrey, at first, it didn't bother me. It didn't bother me, but when I was told, it's like I was told that there was another survivor that got pregnant and was already on a trial on a drug for Gleevec. And once she got pregnant, she was taken out from the treatment. And then once she wanted to go back, and she was told she can't go back. It's either she has to buy the drug, which costed about 30,000 by then. So when they told me that I must make sure that I don't get pregnant, because of if I do, then there will be no treatment for me. And I thought, okay, it's fine. I won't be, at that time, I was not actually sexually active by then.
Okay. And so the doctors then said to you, you may not get pregnant. So you actually told us now why. But you actually got pregnant, and you hid it for quite a while from the doctors. What was their reaction, and from the staff, CHOC staff? But what was the reaction from the team when they heard that you were pregnant?
I heard it from the doctors because I was still doing all the tests and everything, because I knew that when I go to them and let them know, they'll be asking me too many questions, that I would needed some answers that I already have. And for them, they were very surprised, and they all wanted to know, is everything been done? Have you been to the ANC? Did they check you? Do the doctors that are dealing with you with the trial know, and everything? So I already had the answers on my hand that, yes, I've done that. Have you been to the ANC? Yes, I've been. So all the answers I had, so they didn't have any problem with that when I got all the answers. So that is why I kept it long. And as well, I didn't know up until I knew that I was 3 months pregnant already. So yeah.
Yeah, I can remember we were all very excited, but when the doctors tell you you must not, you cannot get pregnant, or you should not get pregnant, you know, you worry about somebody that you love, and you worry, will they be okay? Will they go? Will they carry the baby to term, etc.? And it is a concern. But then you gave birth to beautiful little Zoe. By the way, how is Zoe? Zoe, is she well?
Zoe is very well. She's very well. Yeah.
How old is she now?
She'll be turning 12 in July.
Can you believe it? Can you believe it? Would you have done anything different, thinking back of over your life?
No, Audrey, nothing I would have changed because of now I've got a friend next to me. Zoe's my friend. She's always with me wherever I go. So I've got a new friend with me. So nothing I could have made it to change, nothing at all.
Yeah. So Zuki, as a mom, as a childhood cancer survivor, as somebody who nearly died but was saved miraculously, what is your message to other women who are childhood cancer survivors?
To other women or the childhood cancer survivors out there, I would like to say that when something that it's like, if you becoming pregnant, I'll just talk about sexuality. If you become pregnant or like being sexual, you need to like talk to your doctors, approach them, speak to them, because of sometimes if the doctors ask us if we are already, are we active, sexually active, but we deny to say, no, we are not, because of we don't like communicating with the doctors. But I would say that feel free to ask your doctors because of they know best for us. And yeah, continue to communicate with other survivors as well. How did they feel? How did they go through in anything? If they had any challenges, then you can get out of something that you can get something out of it.
You were a teenager when you were diagnosed and when you went through your cancer journey. If you reflect back, do you think it would have been difficult for you? You're now a matured woman, but as a teenager, do you think it would have been difficult to speak to your doctors about sexuality?
Yes, it will. It will have been, because of, I remember even when I was in hospital. So whenever you go for your checkups, the doctors will ask, "Are you sexually active?" And you say, "No, I'm not." And they could see that maybe something is like wrong, or they can see that, no, this one is sexually active. But they wanted to like to prevent and let you know what is right and what is wrong. But yeah.
Suki, it is. I'm always so thankful when I listen to your stories and when I hear you talk about the miracle in your life. And I think your biggest miracle is not your life, but your little girl Zoe. And you were courageous and you went through with it. And I want to wish you and Zoe everything of the best. May you really be blessed and have a very long and happy life together. And may you become a granny to even enjoy your grandkids also one day. Thank you, Zuki, for being on.
Thank you so much, Audrey. Thank you.
Thank you. So I've got another poll question, and I think I am going to put it up. I want to know, as a childhood cancer survivor, did you know that you could preserve your seed or eggs for future fertilization? And I wonder if survivors knew that. Can you please take your time and answer the question for us? Quickly going to look. If you're ready, we'll give you a little time just to answer the question. Are there any results in yet? Can you please, as a childhood cancer survivor, did you know that you could preserve your seed or eggs for future fertilization? And you can answer yes, no, or I don't know. There's another question that came in. It is from an anonymous attendee. You are also most welcome. It says, Wayne, I think you can take down. We will look at the results later. Oh, 20 seconds. Okay.
Would you like me to answer the question, or?
I'm going to ask the question quickly. We just want to finish the poll question. He's sharing it now. Okay, that's interesting. As a childhood cancer survivor, did you know that you could preserve your seed or eggs for future fertilization? 33% said yes, and 67% said no. We've got a lot of advocacy to do, and we need to learn to talk about this very sensitive topic. Marianne, would you like to answer this question now, or would you like to answer it after your talk?
I think Irene can answer the question.
Okay, so the question was, I'm 16 and was diagnosed with leukemia at the age of 5. Could polycystic ovary syndrome be a result of the chemotherapy treatment?
Yes, thank you for this question. Actually, we do get this question quite a lot. And the answer is, we think no. Everybody can develop a PCOS, but we don't think it's a result of the treatment you've had as a child. We do advise women with PCOS, especially when you are young, to go to the gynecologist and talk about this and maybe do some research or some examination, thank you, with the gynae about this, yeah.
Thank you very much. Thank you. So our last speaker for today is Dr. Marianne van der Wetering, and she's a pediatric oncologist at the Princess Maxima Center for Pediatric Oncology and is active in the field of fertility preservation. She's, as we previously said, Marianne is no stranger to the pediatric oncology community in South Africa. I think you studied at WITS, if I'm not mistaken. Yes. So welcome back, even though it's virtual. We appreciate you and your team's willingness to speak on this sensitive topic. Marianne is going to talk to us about new trends and developments in fertility preservation and the possibilities for the future. Marianne, over to you. Can't wait to hear your talk.
Thank you for your kind introduction, and it's so nice to give a talk for CHOC now. Yeah, I did my whole pediatric training and pediatric oncology training at WITS, and so you are all close to my heart, and I still come to South Africa a lot and visit Baragwanath, or Chris Hani Memorial as it is called now. Okay, I'll give my talk because I'm always can talk for hours on South Africa if you want to hear the talk. I'm trying to share. Open. Okay, can you see it? Yeah.
No, we can't see it yet. Wayne, can you maybe
Marianne,
help?
Marianne, when you share your screen, just share the screen that your presentation is on.
Yeah.
En dan moet je de rechtse of volledig scherm. Ja, als je die aanzet en dan in het midden tikken. En dan op de. Dat zou dus niemand hebben als je niet een presentatie hebt.
There you go.
Yeah, I'm not there yet. Wait. Yeah. Okay, you can see here. Well, this is about fertility preservation methods, and I'm very pleased to say that the world is far more busy with getting this in place. And I think that is far better than when I worked about 10 years ago. And what helps is that we made guidelines for during and before cancer. So at least there are guidelines now for the young child and the young adult, the young adolescent cancer patient, for both females, males, and there's one for ethics and communication. And I'm not going to go through all of this, but in these guidelines, we always have like a robot system where green is the things you absolutely do, orange is the things you maybe do, and red is not recommended. And what we always want to promote is that we talk about it and we inform and counsel the patients. And who do we have to counsel specifically is the ones that are at high risk for infertility. And high risk is more than 80% chance of being infertile later on. And this is what Helena van der Paal already told us, that cyclophosphamide is an extremely important drug, and equivalents of this are also important. And if you get that in a certain dose, then it will give you a high risk of infertility. Same for radiotherapy, same for surgery, and a little bit lower on the list are your transplant patients. What can we do for girls? Well, if you're an adult and you have a wish for an embryo, you can, of course, do hormone stimulation and go towards an embryo transfer. But this pathway we don't see in children. We never see in children. The bigger girls, so girls from 16-year-old or older, there we can mature oocytes by hormone stimulation. And we do that not often. I think it's once or twice a year in this hospital where we have 600 new patients a year. But we can do it this way, and you can imagine that you only do this if you have time. And we don't have that much time often in childhood oncology. So most of the cases, the little kids who are at high risk for infertility, we offer them to freeze an ovary. One of the ovaries is taken out by laparoscopy, and ovarian strips are frozen and used for later life. If we go into the first option of freezing of the oocytes, we call this sort of an emergency IVF treatment. And as I said, you need 2 to 3 weeks of hormone stimulation. And it's quite invasive. For young girls, this is so invasive that we do this under anesthetic, the vaginal oocyte punctures. And obviously, you have to do this before the start of chemotherapy, or at least a year after stopping chemotherapy. As I said, we hardly do it here. The occasional kid older than 16 who needs a transplant, hasn't had anything before, those kids are the ones we can do this with. but it's not very often done. Success rate is 45% of live-born child per oocyte. Disadvantage is you sometimes have an empty follicle stimulation. So then after this whole hormone stimulation, you still don't have any ripe follicles. So that sort of can be very disappointing. So what we often do in this hospital and all over the world is we offer in the high risk for infertility girls ovarian freezing. So as I just said, you do this by laparoscopy. Often we do it together with another surgical procedure like putting in a catheter, portacat. This is done in young girls. We don't do it under a year of age because the anesthetic risk is quite high. That's what the anesthetists think. We're still doing a systematic review on that to see if that is so true that we can't offer it to these little babies. And we preferably do it without any chemotherapy on board, but the girls who have a load of follicles present can have cyclophosphamide on board before we do it. So not too much, obviously, not reaching the 4 grams of cyclophosphamide equivalent dose per square meter. These cortical strips are frozen into individual ampules, and that is kept until later life. Obviously, you have only one ovary left then, so there is a high risk of premature ovarian insufficiency, but this would also be present if you did not do this because of the high risk for infertility. And obviously, we do a whole lot of viral panel to make sure that there's no viruses on board. If you look what we do in this hospital, in 2022, we did about 25 of these ovarian tissue cryopreservations. 25% of our girls were high risk. Of these girls, about 40% had this procedure done, 60% did not. So it's not that all girls to get this procedure, and it will depend on how is the kid at the start. If it's very ill, it's got an abdominal tumor, if it's got an extremely poor prognosis, those are all reasons not to do it. Possibilities for the survivor: either you restore their oocytes, which we stored for later life, and with in vitro fertilization, you can then fertilize and go on to embryo transfer, or you put your strip of cortical strip is thawed, and then it can be replaced into the remaining ovary or into a peritoneal cavity, and then there is a possibility of mothering a child spontaneously, but you can also work with assisted reproductive treatment. And with this, the success rate is about 25 to 30% for a live birth, and there is quite a bit of experience with this technique, but obviously there's still a lot of research going on, especially for the microenvironment of these cortical strips, because the one thing you do not want to do is cause malignancy again by introducing these cortical strips. So there are new techniques going on, isolating the oocyte and transplanting it in a clean matrix. Then I'll go on to the boys, same kind of robots with green, you do, orange, you maybe do, and red, you don't do. And if you look in the boys, the high risk of infertility, they're just a little bit more sensitive than girls. So the lower dose of cyclophosphamide, a lower dose of radiotherapy can make them at high risk for infertility. What can we do for the boys? Pubertal and post-pubertal, the easiest way is sperm cryopreservation. If that is not an option, then you can do surgical sperm collection. It's called a teaser in Dutch. I have no idea. It's a testicular sperm extraction. So it is a biopsy where you extract the sperm. But that is also only done twice, 3 times a year in this hospital. So most of the kids, they undergo sperm cryopreservation, and the young ones, the little ones, so pre-pubertal, they are offered testicular tissue cryopreservation only in research. So there is a research protocol going on, and we are not the only center where that is done. It's done in a lot of other centers as well. And with this, we have done about 63 cryopreservations, including the testicular biopsies. In the boys, there's 35% high risk infertility, and nearly 60% had cryopreservation done. This is how the biopsy technique is done. So you take about 1/3 of the volume of the testis, done by the urologist under anesthetic, again with another procedure at the same time. So it gives only once under anesthetic, and it's well tolerated and safe. So there are not many wound complications. The kid can start chemotherapy actually the same day. He has a little bit of pain for the first few days, which we handle with paracetamol, so not more than that. We are now organized in a whole consortium. We only started this in 2021, where you can see that Europe is highlighted, a lot of stars where these testicular biopsies are done, but also Australia, also the States, also Spain. So I think we must add South Africa to that. The thing is about this, it's still in research, because the second step, as I was telling you, the step with girls that we can actually restore the ovarian tissue and mother a child, well, that step has not been done in boys yet. It has been done in mice, and the proof of principle in mice is wonderful. They've done this to the 3rd generation, and it's fine. Normal mice, no genetic problems, and went well into adulthood. And we have done it in monkeys, autotransplantation. So the next step will be in humans, and I am sure that step will be there in the next 5 years. So that is why we are offering our children this possibility, in the hope that they can use it later on in life. When you are at the outpatient clinic and you're a survivor, I think Helene has told you a little bit about this already, but this is the most important step for men to do, is your semen analysis, preferably 6 months after oncology treatment, as you have a whole new set of spermatozoa then. And this result has to be communicated back to the patient by the physician or someone specialized in oncofertility. So that can be checked if this was done in the correct way, if the person was in a good clinical condition, if he didn't have an infection at that stage, medication use, anything that can influence the semen analysis. And if azoospermia, repeat the analysis before you definitely can tell this person that there is no spermatozoa. If fertility preservation was done at the start of the treatment, this will be kept for you till you need it. Then the possibility of assisted reproductive treatment will be there. And there's about 35 to 40% chance that you will father a child. So there are a lot of possibilities, and there's a lot to do in research and a lot coming up. So yeah, I think we must talk about it and look at it at the start of treatment and talk about it at the end of treatment. And that's it.
Thank you, Marianne. And I think the most important comment that you made was that we must speak before the treatment and we must speak after the treatment. There needs to be a conversation on this. And I'm so thankful for all the research, because we do want our survivors to have happy, long lives, bearing their children, becoming mothers, fathers, grandmothers, grandfathers. And we cannot do that without the wonderful research that is being done in the hospitals. Thank you so much for your time. I want to say that I want to first of all start by saying thank you very much for everybody. We've answered all the questions in the chat, so I don't think there's any more questions, and we are on time now. So thank you very, very much for Mariana, Helen, and Irene. Thank you. That was amazing information, and we're so thankful that you took time to speak to us, not only South Africa, but there are participants from all over the world. Thank you, Zuki. I always love your story. Travel safely when you go home. Thank you to the technical team, the brand race who always helps us. This video, we find that we have a lot of footage on the webinars when it goes to YouTube. So please promote it amongst your fellow colleagues, the survivors. We can all learn from this information. Thank you to Taryn and Musi and the CHOC staff. Thank you to everyone who attended, and we hope that the new knowledge and information will help healthcare professionals who need to break the news to patients, but also to survivors who need to make very important decisions in their lives and choices in their lives. So our next webinar is on the 28th of June. And then we're going to look at how do you speak to the survivors. And we have a very well-known South African psychologist who's going to talk and who specializes in fertility is going to talk. We've got 2 more survivors that's going to talk. And our last webinar will be on the 26th of July. And our keynote speaker there will be Sage Balti from Fairfax in Virginia. And I heard her talk at the SAD conference in Lyon, and it blew my mind. So please spread the news. Come and join the webinars. Look it on YouTube again. Share it with your friends and colleagues. But most of all, share it with the the survivors, because it's them that we want to empower with new knowledge and information. Thank you to everybody. Go well, travel safely, and love your bodies and love your sexual self. Thank you very much.
Thank you, Adri.
Bye-bye.
Bye,
Bye, everybody. Bye.